Good afternoon, everyone. My name is Rocco Fusillo, and I'm with West Virginia University in State and Local and Corporate Relations. And it's my honor and pleasure to be here today for a couple of reasons. One is I look at North Central West Virginia as one big region. And anything we can do, there's a region, but also one community. And anything we can do to develop this community is really important, I believe, to all of us. And it's for me for two reasons, both personally and professionally. Professionally, as my job at West Virginia University, we're committed to helping develop the whole area as one region and one community. Secondly, personally, I grew up in Fairmont. I live in Clarksburg, and I work in Morgantown, and graduated from Fairmont and WVU both. So I'm very passionate about the belief that anything we can do to focus efforts on North Central West Virginia and to understand what happens in one city or one county benefits the whole region. And the more that we have events like that's going to be great. And also, I'm a former Cabinet Secretary of the Department of Health and Human Resources, and that lets me know how blessed we are to have the organizations that are represented up here and what they provide to healthcare that probably no other part of the state can boast about. And they're important for three reasons. One, because of the quality of healthcare that they provide. Secondly, because they're an economic driver of the economy based upon the jobs and economic activity they create. And thirdly, because of an issue we've been talking about a lot today through all the panels, is the importance of healthcare for all your businesses in the case of workforce development, participation rate, and the health of your workforce is all tied to healthcare. And I can't think of anyone better to lead this discussion than one of the leaders in healthcare in West Virginia. And I want to now introduce you to our moderator, Mr. Joseph Litnachin, who is the President and CEO of the West Virginia Hospital Association. Please join me in welcoming Joe.
Good afternoon, everybody. Thanks for being here, and thanks for having us, and welcome our panel. I thought it would be helpful from a healthcare perspective to put into perspective what goes on with our hospitals across the state. We represent 65 hospitals and health systems throughout the state, covering obviously the whole region of West Virginia. Our hospitals have we employ 45,000 people. We have about a $3 million annual payroll in our hospitals. These are good jobs. They touch the lives of patients and families every day. They are not outsourced, and they are jobs that are meaningful here in West Virginia. We have an economic impact of close to $9 billion in the region between what we provide as hospitals to our employees, what they then do in the region as far as their spending and economic benefit to the region. So I thought that piece of information was helpful as we talk about economic development. And these representatives of our 6 facilities, which represent more than 6 globally in our state, they represent a big component of that from an employment perspective, from a payroll perspective, and from an economic perspective within the area. Our primary challenges as hospitals, other than dealing with reduced payments at the state level from the Medicaid program. A few of us were down in Washington last week dealing with the annual ongoing payment cuts to hospitals by the Medicare program and other components that we deal with. One of the other challenges that we have is our pipeline for the workforce. And that gets into the education. We had that panel before, and even on the primary education level, math and science are the important skill set that our hospitals need as we try to have people trained to become healthcare providers, whether that's nursing, whether that's in the tech, radiology tech, lab tech, or many of the other areas. If you can get through the education system with math, sciences, and the like, you can have a great career in education. I know it as a father of a nurse, daughter nurse, and 2 daughters-in-law that are nurses. They have great careers. They've gone different paths. They have flexibility, and my daughter uses that to the maximum benefit as a mother of 3, but also a pediatric nurse. So it's a great, great industry that we want to give you a chance to hear a little about and let them tell their story today. I'll do a quick introduction of our panel. This is a huge panel, but obviously in the 3-county area we have many healthcare providers, and the first next to me is Mike Kasdorf from Highland Clarksburg Hospital. That is the new facility. It's not so much new now, but it took over the campus of the old United Hospital Center before they moved on to their new campus. And Mike Kasdorf has been there from the ground up. He started with the conversion of the facility into a behavioral health facility. Mike saw that all the way through since 2008, and he's now the CEO of the facility, running the organization, which is with their sister facility down in Highland Hospital in Charleston. Next to Mike is Peggy Kasdorf. Peggy is at Fairmont Regional, or what did I say? Peggy Coster, not Kasdorf.
Yeah.
At Fairmont
really
Regional. He likes her, but not that much. They have the same name. At Fairmont Regional Medical Center, obviously Fairmont's gone through a lot of changes, and Peggy's at the helm. She was tapped to become CEO after more than 35 years in the nursing profession. She was a nursing executive at the hospital, and she is running that facility. And again, all the changes that they're going through, and I've had the privilege of working with Peggy and her boss throughout the process, and they're making a difference in the Fairmont area. Next to Peggy is Mike Tillman from United Hospital, in the new United Hospital building at exit 124 that you see up on the hill. And I remember them watching all that dirt that they moved to build that place. Mike, your CEO in 6 days, formally, I guess.
About.
He's really been doing the work. Bruce Carter is retiring, and Mike has been honored to be appointed as the CEO there. He will formally take over, but he's been involved with the hospital for several years, and all of the great things that they do at UHC. And UHC is part of the WVU United Health System, which next to Mike is Dr. Christopher Kalenda, who is the president and CEO of West Virginia United Health System here in Fairmont. Did you walk over here, Chris? Or? That is a 7-facility system right now, and Dr. Kalenda is the former chancellor of the Health Sciences Center at WVU, and he's been in a role at WVU United Health System for about 1.5 years, and obviously making a huge impact with his footprint since he's been in that capacity. And he is a board member at the Hospital Association on our Board of Trustees. Next to Dr. Kalenda is Darrell Duncan. Darrell is president and CEO of the Mon Health System in Morgantown. Darrell's also a board member of WVHA. He's operating a system with Mon Health System. They also have Preston Memorial Hospital, which is a new hospital which will be opening in May. So that's another new facility that we'll have here in the state. And you can see the footprint is expanding, and WVU's footprint is expanding around the state to other parts out to the eastern panhandle and parts in between. So you can see how the healthcare system regionally or locally here is becoming regionally and able to provide more care and better referral patterns and better services for their patients. And then next to Darrell at the Lewis A. Johnson VA Medical Center is Beth Brown. Obviously, we're blessed to have the number of veterans that we have in our state, and the role of the VA health system and the individual facilities is to provide that balance of healthcare, inpatient, outpatient services, have the care that's available for them. And Beth does a great job providing those services here in this region. So you can see we have behavioral health, we have acute care, we have large, we have medium size, and then we have the VA system in there. So let me start with throwing a question to the panel members, and we'll just kind of go across, starting with Mike, and then we'll get to some questions from the audiences after we go through some with the panel. Well, I guess the first point is to the panelists here. What do you think are some of the biggest challenges facing West Virginia with our healthcare delivery system, and in particularly within your organization or at your facility? So we'll start with Mike.
Thanks, Joe. We're a brand new facility, so a lot of our challenges are different than what some of the other panelists may have with you. We opened in August of 2013, where we converted the United Hospital Center to a psychiatric facility. A lot of the challenges that we face now are referrals, getting patients into the facility. Patients just don't show up at our doorstep. They are referred to us through schools, counselors, emergency rooms, outpatient clinics. So that's one of our biggest challenges, is getting patients into our facility. Part of that is the communications and getting our name out, letting people know that Highland-Clarksburg is here. We are a resource that we can address the mental health and behavioral health needs of folks in North Central West Virginia. Part of that process is going to schools, educating the folks about what mental health issues are and what we can do to benefit them as we go forward with it. Our other biggest challenge that we continue to face is the recruitment of professional staff to this area. We're really challenged on the recruiting of psychiatrists to get them into this area. We have not been very successful in doing that. We're lucky that we have some very good doctors from West Virginia University that are working with us at our facility. But recruiting of RNs and therapists and also psychiatrists is a very real challenge that we continue to face.
Well, it's a pleasure to be here today, to be with you. One of the biggest challenges I feel that we're facing at Fairmont Regional Medical Center actually deals with the Affordable Care Act. And we are all asked, every one of us up here, to do more for less. It's the same way we heard this in the previous session with education, and now I really am saying that again. They are expecting high quality measures from us, which every one of us are working so hard to accomplish. But our reimbursement will be, affected if we fall below the expected quality measure. The government wants to see quality, and they want to see efficiency. One of the things that I've spoken with Joe about that I have thought was a problem for every institution is the 30-day readmit rate for all cause. And for those of you that may not realize this, the hospitals can be penalized if a patient with, let's say, congestive heart failure is discharged and they come back within 30 days for any cause. The hospital can suffer from that. And so I think that, we really, I've talked to Joe about it, and I know that he's probably taken that to DC in his discussions, but we need to have a fairness about, where we're being penalized. The other thing I see too is what Medicare reimbursements are going to do to the elderly. In the Marion County area, we have a huge elderly population, and that many Medicare cuts may affect the elderly there, and they will also maybe affect their copayments. So we want to make sure that the elderly are taken care of. And I agree with Mike. We do, we are recruiting for RNs and LPNs and nurse aides at our facility, and I think that as we go down the panel, we will hear that, across the panel. So, Mike.
Joe, thank you for that. Thank you for that kind introduction, and it's a pleasure to be here. Acute care community hospitals have an incredible breadth of mission across everything we do. We're here for you when you have a car accident on Route 50 at 2 in the morning, and we also take care of the homeless fellow in downtown Clarksburg who has a cough 24/7, 7 days a week. And in 1, 2, 3, you hear right away, in order to complete that mission, in order to fulfill that mission, you hear recruitment from your first, second, and third panelists, and I would echo that. Recruitment of physicians primarily, we're not really having trouble. We have to stay on top of ancillaries and nurses and pharmacists, but recruitment of physicians is definitely our highest priority in order to fulfill that mission.
Good afternoon. From the West Virginia United Health System, we have multiple missions that reflect the origin of the health system that began in 1996. We actually were formed as a confederation of hospitals across the state, and as Joe mentioned, we now have 7 hospitals that are a part of the system, and we're very much regionally focused, but we also move from a community perspective in terms of healthcare delivery to regional communities, but also up to the academic mission in terms of training the next generation of health professionals, whether it's physicians, nurses, physical therapists, occupational therapists, nurses, dentists. One of our anchor hospitals, Ruby Memorial Hospital, is in fact the largest provider of health professional training in the state of West Virginia. But we also are facing, I think, within an industry, we're also facing the challenges of not only reimbursement, but the consolidation of facilities into larger and larger systems. And that requires us to be fairly nimble in terms of our decision-making as well as our organization and structure. So one of the things that we are faced with here within the system is how do we address population health. If you look at where our hospitals are, there are about 1 million individuals that are layered into the regions that are where our hospitals are. And so how do we appropriately partner with other systems? How do we develop a systems-based practice that allows patients to be able to access primary care through community-based specialty care to pre-acute care, acute care, whether it's at a community hospital or an academic medical center, to post-acute care and long-term care. So one of the challenges and also one of the opportunities for a large system like the West Virginia United Health System is to be able to think about systems-based practice to be able to deliver healthcare services across the continuum of care.
You know, one of the challenges of being the fifth guy in a panel is you can't even remember the question.
You get first up next time.
I'll try to answer it in a more global way. You know, West Virginia, we have the second highest population of a state, second highest oldest population of a state in the country. I think we're slightly behind Vermont. So that means we have higher utilization on a per capita basis than most places. So we use hospitals more than most. We have a third of our population now, with the expansion of the Medicaid program, a third of our population is on Medicaid. So we have high utilization, and a third of our population actually pays substantially less than cost, somewhere around 65 cents on the dollar. So those are two challenges our health system has. We don't have enough primary care access points in the state. We don't have enough primary care doctors. So that you take those three together. So we have high utilization. We get paid for about a third of our population, about 65 cents on the dollar for cost. And we really don't have enough access points to get care to people if they had insurance or not. So those are fairly big, broad challenges I think we have as a state. And I think if you look at it from an economic development standpoint, every small business that considers West Virginia as a location where they want to put their business, they're going to be looking at roads, utilities, schools, and healthcare. And so we have to make sure that there's access points in these communities so that high quality, accessible, affordable healthcare is there so we can continue economic development. So I think that as a broad picture, we have a lot of challenges as that goes. I will echo what the previous panelists said about recruitment. That in our case, a lot of the entry-level jobs are the most challenging. So the folks like housekeeping and dietary, medical assistants, those have been extremely challenging, high turnover positions that have been difficult to fill. Mostly because if you look at our area, hotels have gone up, restaurants have gone up. A lot of those folks we used to hire, we have a lot of competition for now. So that's really making things a little bit more challenging.
Well, as the VA hospital, our challenges are a little bit different. You probably saw we did get a lot of attention last year regarding access. But access here is no different than access in the community. As you've heard the other panels say, some of the challenges that we have is where are we going to find providers? Where are we going to find mental health providers? And I can say that in talking with many of my colleagues, it's not just unique to West Virginia, but I think our challenge is affordable housing. If I do find somebody that's willing to come, can they find a house that's comparable to what they had in another location? One of our biggest challenges is how do we deal with the homeless population? We do have a number of people that are homeless, as we all know, but part of the challenge that we have is how do we find them a place in which to live? Because many of the challenges that we face have to deal with lifestyle choices. So in those individuals that have a substance abuse issue, who no longer have that available couch or that available sofa in the basement, become the next generation that we have to deal with. So we've been doing a lot of partnering with the community to find affordable housing. We have had VASH vouchers, but for $800, do you know where you can find a place to rent for $800 that includes utilities? Not too many. So we've been very fortunate that there are people within the community that have been willing to partner with us to build some opportunities for our veterans. So we have many challenges, just like the other panels. How do you recruit to a rural area? Once they get here, do you provide the services, the education, the shopping experiences that they want? Because we oftentimes will have people come from another area that will say, gee, this is not going to work for my family. So I think we have many, many challenges. As I said, many of the things that we're faced with are choices that our veterans have made during time, whether it was when they were in the service or afterwards in dealing with their transition back to the community. And I depend, and we rely very heavily upon our other counterparts in the community to be able to provide the services that we cannot.
And it's interesting, as you look at this group of CEOs here, call them competitors with small c. Obviously, they have their own facilities, but they're also partners because the acute care is working with behavioral health, they're working with the VA system, and patients going back and forth. But our overall goal is we're all in this together to improve the health of the people that we serve within the state. Some takeaways from the group that just spoke on that first question. We are one of the oldest, sickest, and poorest states in the country. I mean, that's backed by statistics. We have chronic conditions that we're very high on. Number one, we have the trifecta for diabetes, obesity, and a high level of smoking and cancer. So we're starting out in a deficit, and their challenge is to constantly treat these patients. And also, there's some component of personal responsibility with the patients. But as Peggy talked about with penalties, yesterday was the 5-year anniversary of the Accountable Care Act, affectionately known as Obamacare. 5 years ago yesterday. We are now just starting to experience the cuts. We had cuts in the first 5 years to pay for that. We were cut significantly. Our estimate at the beginning was hospitals would take about a $1.3 billion payment reduction over the 10 years. So we're starting our 6th year of that. But the other thing we're seeing is with these readmissions, if you think of Consumer Reports, how they rate facilities or rate cars, for example, or rate appliances, they put them in quartiles. And the bottom quartile may not mean it's a bad car or a bad appliance, but because they're in the lower quartile, maybe by 1/10 of 1% or 1/4%, the hospitals in the lowest quartile in the state get a financial penalty, whether it's for infection rates, whether it's for readmissions or something called value-based purchasing. Obamacare was set up so that the hospitals will have financial penalties because that's how they're paying for the other component to give people coverage. So no matter what these hospitals do, they're going to face penalties that kicked in this year in October in 2014, and that's the challenge that they're dealing with. So that's an ongoing piece. Let me throw one more question out, and then we'll turn it over to the audience. And Darrell, we'll start with you. See if you can remember this one.
I can remember.
You'll get to me later. But as we talk here with the 3 chambers and with the three counties that we're dealing with, our hospitals obviously play a big role in the economic development of our state. We're going to see more hospitals with mergers, affiliations, acquisitions. You can call it partnerships, but it's happening. It's happening for a lot of reasons. And that's not necessarily a bad thing, it's just happening. What do you see as the potential in the area for your facility to provide some more economic growth to this region, and how your hospital and health system will play a role in that economic development? And then I'll tap the others.
Thanks, Joe. Over the last 9 years, Mon Health Systems invested about $150 million in our facilities. And that includes, in May, we're going to be opening a brand new hospital in Preston and Kingwood, $38.5 million investment in that community. healthcare is expensive. We all know it's too expensive. And one of the things that concerns me, particularly here in West Virginia, is if you look at those who are employed by healthcare, we're probably the second, third largest industry in the state. That's not a good formula. We are a cost to employers. Although we are an economic engine unto ourselves, we are a cost to everybody else. So if we're the third largest employer in the state, that's somewhat of an issue. We have to do better than that. So that's a challenge going forward for us. It's a bigger challenge in our state because of our population, that it's older and poorer and more diverse. We have folks living up crooked roads and hollers, and it makes things more challenging because of where they live. And the goal, at least the way we see it, is you got to get health care closer to those folks because they're going to be more apt to be compliant. It's going to be less costly than bringing them to some big hospital someplace. And so that's going to be a continuing challenge for us, is to figure out how we can use technology to our advantage. I was just at an educational seminar last week in Chicago, and we were talking about the advent of biosensors. And so that's going to help, I think, rural areas a lot in the sense that you could give a patient a biosensor, and we can monitor that patient in their home. We could tell their weights, their temperature, whether or not they're starting to get an infection, whether they're putting on water, all those kinds of things that we now have to bring them in for that they're not going to be compliant to do. And we can monitor that stuff and intervene much more quickly and prevent them from actually having to come to the hospital. The whole idea of the Affordable Care Act, whether you're against it or for it, the whole idea of the Affordable Care Act is we've got to change the milieu of caring for sickness and start focusing on wellness. And so we've got a whole economic engine out here that's built and developed and focused on keeping doing procedures and taking care of sick people. And we want to take that same amount of energy and economic investment and focus it on keeping people healthy. That's sort of like trying to change a barge in a narrow river, the direction of that barge in a very narrow river. It's going to be very hard to do, particularly in a rural state. But I think the good news is we've got a lot of resources in north central West Virginia that are working on it, that we're focused on it, and we have to partner with the businesses in the communities to do a better job at it.
Chris?
I would concur with everything that Darryl said. How many of you have smartphones? Okay. This is disruptive technology that could transform healthcare delivery in the 21st century, because on this I have my actigraph, so that it measures how many steps I take a day. But we're also going to be seeing the application of FaceTime or Skype or Google Time in terms of being able to access patients in rural settings, where they will call into a call center and actually have a point of contact with a healthcare professional, whether it's a physician or an advanced practice nurse or whomever. I would agree with Darryl. One of the things I learned when I was in administration school 35 years ago now was that healthcare is a cost center. We don't produce much. We're a service industry. And what has happened, I think, over the last 35 years is that as you look at biomedical technology and the infrastructure that's associated with the new industries of the 21st century, healthcare is not only a stimulus for economic development, but it's also a recipient of the novel inventions and applications of technology to healthcare delivery. And the last thing I'll say that is that, as you've heard people talk about, historically we were measured on how much we did for folks, what we call volume of services, and you've heard a little bit about how this is shifting to value, how well we are performing, whether it's a quality or whether it's delivering services at the right place, at the right time, in the right location for patients, so that they don't use high-end, expensive healthcare services, we are really in that transformational period in this decade and in the future decades of looking to how do we rationalize, not rationalize in terms of withholding, but how do we give care that's at the place where patients should be receiving care in their homes, in their communities, or in the hospitals that we all are responsible for.
As Joe mentioned, I'm a new CEO, and so as part of my learning process, I've spent some time looking at rural clinics, and we run clinics in Pennsboro, in Barber County, and most of my healthcare experience has been in an acute hospital with the shiny tools, the linear accelerator, all the fancy things. But healthcare really is a local function. And so when you're sick, you go to a doctor. And when you start to go to some of these rural clinics, you really realize that that's almost we have to shift the engine from the acute care hospital to the place that the patient really needs healthcare. And that'll involve technology and communication technology, having the right primary care providers, but also making sure that that patient can access a specialist easily, conveniently, when they need it. And I guess that's the message of economic development is care at the right place at the right time. But much of the time when you try to measure economic development or you treat healthcare as a commodity, you get into this phrase people use. They talk about healthcare as a value and how do you measure the value, and sort of changing directions here a little bit. But Peggy talked about the measures of healthcare and how we get penalized for readmissions, which then affects us economically. And I actually looked at a spreadsheet this morning. We track readmissions by 3 days, by 7 days, by 20 days, and by 30 days, depending on 5 or 6 different payers. But the biggest determinant of readmissions is really socioeconomic status. If you have a hip replacement and you go home and you get discharged and your wife takes care of you, your husband takes care of you, and you get your dressing changed appropriately and you get physical therapy, someone rides you back and forth, your outcome, your lack of a readmission will probably be very good. If you get discharged to a homeless shelter and you don't have follow-up physical therapy, there's no one who really looks at your wound, you don't have follow-up, then chances are you come back to the hospital. So part of our mission in this economic development is to make sure that we value, that we measure the right things, and that the rewards are for the right incentives.
Well, I agree with Daryl in that our focus needs to shift toward prevention. It seems like on our end, what we see the patients that are coming here to us with chest pain that, maybe 10 years prior, we could have done something, to prevent that from happening. And it's unfortunate, but it's the same way in the school system. I mean, our population is overweight. We do have high incidence of heart disease. We also have high incidence of cancer. And so at some point, when are we all going to start to work together, to improve the health of the entire population? And everyone pretty much looks to healthcare facilities to lead that challenge, but it takes a whole entire group effort, whether it would be education, whether it's industry, along with healthcare, along with the government and communities to make that change. And so for us to really make an impact, that's what we really need to be working toward.
On the mental health side, when you think about mental health, one of the issues that we're always facing is the stigma associated with mental health, whether it's depression, anxiety, PTSD disorders, whatever. There's always a stigma associated with it. And one of the things that we need to focus on is working with the partners within the state on what are the needs. One of the needs that we've seen at Highland is at any point in time, there are over 300 children in our state who are out of state getting care in psychiatric residential treatment facilities, simply because we do not have those facilities inside our state. So one of the real needs is working with the state, identifying what the age and population that we need to address, and then setting down and getting the facilities built in order to address those needs. Part of the issue, honestly, is the certificate of need process that you have to go through, get the approvals through the healthcare authority, get the process moving. It can take a lot of time in order to get a lot of the stuff moving forward and get it done. But it's part of the process. It's part of what we have to do as a facility in serving the needs of our folks.
Beth, your world's a little different. It's a different payer, right?
Could I see a show of hands of who our veterans are in the group? Well, thank you first for your service. I think West Virginia has the unique opportunity to serve its veterans because 1 in 7 to 9 is a veteran. And when I often ask the question, do you know a veteran? I think everybody knows a veteran. You've either related to one, you're married to one, your dad or your mother or your aunt or uncle were veterans. And so we have a proud service of our veterans. We have 77,000 veterans in north central West Virginia, and we serve about 22,000. So our mission is a little bit different, but it's all the same because we're here to take care of each other. We have the opportunity of providing health care not only in Clarksburg, but in 4 rural areas, Tucker County, Braxton County, Monongalia, and Wood, through our community-based outpatient clinics. And we have a rural mobile unit that also goes into the hollers as well. That's a smaller population, but it's an important population. And what we saw this winter is if you can't get down the road, how are you going to get health care? So what the VA has done is to partner with the communities in how we can improve health care. We do a lot of, and I was actually at the same conference you were last week at that same session, about how can we provide care closer to home through technology. So through the use of telehealth, where we can be able to provide Skyping or FaceTime with friends in real-time modality, we can actually, in our rural clinics, provide health care and mental health to a veteran who's connected to somebody on the other end. It was a little bit getting used to, but when you sell it like Skype or FaceTime with friends, anybody can do that if you've got one of those smartphones. But what we have found is that once that comfort level is there, they don't even notice that they're talking to somebody who's not in the room. And I see that that is the direction in which healthcare is going to go in the near future. I oftentimes joke because if you are a Star Trek fan, you see some of the things that were out there 30 years ago, and it's reality. A CAT scan, a PET scan, an MRI, those things were never even thought about probably 40 years ago. So we're able to do a lot of things locally, which makes it a little bit different than my counterparts here because of the technology that the VA can connect with anywhere. I can have a doctor, in fact I do have some physicians up in Butler, Pennsylvania, that do an amputee clinic with some of our high-risk patients so that I can't have that provider here, but I can connect with them locally and through that telehealth. We are able to do mental health exams. We're able to do pre- and post-surgical clinics with the providers in Pittsburgh so that our patients don't have to go to Pittsburgh post-surgical or pre-surgical or post-surgical for some of that opportunities. Dermatology, wound care, amputation. Home health is probably the one thing that we're going to see a lot more of, where we're actually being able to send a monitor to, as you were talking, the biomonitors, where you're actually able to monitor the patient in the home and find out when there might be a problem and get them into the provider much quickly. At the VA in Clarksburg, we just started a program called Home Health, in which we have a team of individuals that will go out to the home for those high-risk patients or those patients that cannot travel from their home very easily to the hospital, so we're able to keep them in their homes longer. But one of the challenges that we face in the state of West Virginia is a lack of nursing home care beds, specifically geropsychiatric. I've had patients in my hospital for over 30 days not being able to place them into an appropriate environment within the community. And because of the substance abuse and the drug abuse and the mental health illnesses that we see with our population, those are a very difficult group to manage. They're a difficult group to place. And if we have not the nursing home care, then they're going to either linger in our hospitals at a significant cost. They're going to go back home, and in some cases, there's somebody at home that can't take care of them. So then they're going to get dumped. And that's not the right thing for our West Virginians. So I see our mission in partnering with the community as best as we can to provide those services. I think that as healthcare continues to expand, the VA is looking at partnering much more with the community, not only in what services we might be able to purchase from the community, but what kinds of services that we can provide. In fact, UHC and us, about 3 years ago, were able to go into a joint venture in which we were able to purchase a PET CT. UHC was very generous of being able to build the building to place it in, the staff to be able to service that equipment and to do those exams, and then we have priority. So I think that that's how we can meet some of those demands and needs where we would all benefit.
Chris, you have some additional comments?
Yeah, I think one of the things that kind of listening here and kind of synthesizing the things a little bit that's I think important for the audience. In 1975, I was a third-year medical student, and I thought I wanted to be a neurosurgeon. My wife corrected that misperception of myself. But one of the things that was important was I saw disruptive technology in 1975 at MCV Hospital in Richmond, where we had the first CAT scan in the state of Virginia come in, and I was on call one night previously, and we had to do an arteriogram to find a lesion in a patient in the middle of the night. 3 weeks later, when I was on call again, we had this CAT scan that was up and going, and we were able to see that lesion through a CAT scan. And it was interesting. Just a side note, it was built by the company that did Apple Records, which was not Apple Records, but Beatles, the Emmy Corporation. But over the last 30 years, there's been an incredible investment in technology and hospital-based services. And what you're hearing the group talk about now is moving healthcare into the community through disruptive technology. And right now, though, there's not a pay mechanism to allow us to move from hospital-based services or clinic-based services into community-based services. And I think that one of the missed opportunities of the Accountable Care Act was never to really focus on that transition, that leapfrog, if you will, to move into how do we get services into the community and appropriately pay for providers so that they are able to deliver those services in a cost-effective and optimal manner. And the last thing I'll say about that is because we're in an older state, you also heard today the issues of chronic care and long-term care. And we have a significant challenge ahead of us with our generation of individuals who are going to age, and we all want to age in place. But at some point in time, if we don't figure out how to effectively deliver long-term care services, whether they're long-term mental health services or long-term physical health services, we're going to have a significant run on the financial bank of Medicaid, which primarily pays for long-term care services in this state, and other personal resources. So disruptive technology may be the vehicle that will allow us to age in place, that will allow us to manage chronic disease in place, and also allow us to be able to do what's right for patients into the future. Thank you.
So 2 takeaways. Our technology is changing, and I think as Dr. Kalenda said, we're changing how we deliver care faster than how the payers are recognizing how they can pay us for doing it. Because of a lot of things that these hospitals are doing and hospitals around the country, they're not getting paid for. Wellness, preventative care, that's kind of something we do because that's our role, but the payment system's not keeping up with it. Secondly, as you go around this state, I get worked over by a lot of people. They say, oh, we always know where the hospitals are, we just look for the crane. And that's somewhat true. We have old facilities. Many facilities can't be rebuilt from the inside out because they're just old, there's asbestos. and they don't work anymore. The flow put of patients moving from the inpatient model to the outpatient model. I know that every one of these folks have redesigned either internally or with new facilities to better provide care so the outpatient flow works better versus how it did 30 years ago when the patients came into the hospital and stayed there for a long time and left. And then you have the whole issue of private rooms, which gives you privacy. It's better for infections. It's better for a lot of things. And it's the nicer way to receive care than somebody next to you moaning and groaning because they had a treatment, they're not feeling well, whatever. That's the disruptive part of medical care. But I think we need to applaud our facilities for the construction that's going on. It's not cheap, it's expensive, but it's improving care, it's providing better outcomes for our patients. And that's, again, what we are here to do, to provide a better environment and have better outcomes. We have probably about 10 minutes left. I thought I'd throw it out to the audience to see if there's any questions that you may have, because if you don't, I have more, but I thought we'd give you a shot if you want to ask any of these folks questions. The lady in the blue with her hand up.
I wondered if you all have some ideas on how the system could incentivize more medical students or medical professionals to be primary care or family physicians, because there seems to be, for a lot of sensible reasons, people focusing in specialty areas, but what I hear from all of you is that we need more primary care.
Who wants to jump at that now?
As you point out, it's an economic decision for those. It's an economic decision for those students. Is this on? We started our own residency program 2 years ago for that very reason. So we now have 12 family medicine residents at Mon General Hospital. But it's expensive. Teaching a resident is about $150,000 a year. That the first couple of years you don't get paid for that at all. If they see patients in a clinic, you can't bill for that. So it's certainly a challenge. We've tried to encourage medical students who are from West Virginia to stay in West Virginia through residencies and to focus on primary care. But the ultimate challenge is we have to pay primary care physicians more. I mean, if the goal, as we said earlier, we're trying to keep people out of the hospital. That's the goal. The primary care physician is the quarterback of keeping people out of the hospital, and they're the least paid professional physician in the whole on the whole team. So we have to change that economic formula and pay them for what they're worth. Now, we have seen some change in that. Blue Cross, Medicare, others are starting to pay now for wellness visits and what they call the holistic care visits, where you can come in and do a complete physical and they'll pay you for your more time to do that, which is encouraging these primary care physicians to spend more time with their patients. So we're starting to see some change with that, but it's coming very, very slowly.
I'm going to be heretical. I think we have to think about this from a systems perspective, and we need to think about primary care, not primary care physicians. And in terms of that, we need to have our advanced practice nurses, our physician assistants be able to practice at the maximum level of their license and working within healthcare delivery teams. I think that the modern medical student they come in passionate about primary care. It's part of in the interview process. I've sat on admissions committees. It's the interview process. I want to be a primary care doc. But during the course of their medical school career, they are increasing their opportunities to really engage in primary care experiences is somewhat limited by virtue of the curriculum that they experience. But from a care provider now, I think we need to look at primary care from a much broader perspective, not just focused in on physicians. And I know if there are physicians in the audience, I know that that's heretical. But I think if you look at care delivery systems and how to optimize the care delivery system, you've got to simply address that problem directly.
Because we in the VA cannot be a leader when it comes to pay. We are oftentimes in competition with our community. And again, we cannot be a leader, a pay leader. So what we've often found is how do you supplement what we call as a primary care team. So we actually function in teams. So we will have nurse practitioners and physician assistants, those mid-levels, that can do a lot of the, provide a lot of the care and the examinations, and then use our primary care providers for those more high-level interventions that they have to do. So I think that we're all faced with some of the same challenges. Is how do you recruit them to a local facility or a rural facility? They have to want to come to our area. I think we've been very fortunate in the VA in that we've been able to recruit through some incentives that we have through, say, educational offset for some, but it won't cover the full cost. That's how we can partner also with the schools, because we do provide rotations for the residents, and so they get a different perspective when they see the VA patients, because we often deal with a whole host of problems that they might not see in a private practice.
And legislatively this session, we had to bite at that apple with a bill to give advanced practice registered nurses a little more autonomy, and there were the wrangling between the different scopes of practice, and so that's a continued battle at the legislative front and the regulatory front. Anybody else want to weigh in on that? Okay. Any other questions in the audience? Can't believe that. Any closing remarks that any of you folks want to hit? We have a couple of minutes left, but any other thoughts from a healthcare delivery system? Darryl, I know this is a bashful group, so.
Yeah, I just wanted to say something really from an employer perspective. Although we are in healthcare, we're also an employer. We have about 1,700 folks, and I think if you look up here, we've probably got 12 or 15,000
Big component
represented.
That's right.
We do have, as employers, we have to take some responsibility and encouragement for better habits and better lifestyles. And some of the stuff really isn't that expensive. We've started partnering with our TPA, which is Highmark, and we can now look at the claims data, and you can get a holistic picture of what healthcare is going on with your individual employees. And you can actually, and we've employed now, we have a wellness coordinator and a health coach, and we try to sit down with folks who are having health problems and try to get them on a path to where they can start changing their ultimate health status, helping them with their diabetes management, helping them with their weight loss, with the things that they do, how they take medications and so forth. And even though they may be nurses and health professionals and other folks that work in the hospital, that doesn't mean they're any different than the rest of us. So we've invested in coaching with those folks, and I would encourage every employer to do that. In the end, it actually doesn't cost us anything. We're lowering our total cost of health care by investing in keeping those folks healthier. And I would encourage every West Virginia employer to do that.
Certainly.
On that same note, there are some programs available, and we're getting ready to implement one at Highland, where you can give an incentive to the employees to get various wellness initiatives going, and as a result, after a year or so into the program, they can get a reduction in their medical premiums that they have to pay. So there's a lot of things that you can do as an employer to work with your employees to get the wellness initiative going forward by showing them that they can, as you reduce your weight, as you lower your blood pressure, as you do more healthy things, there's a reduction in your overall health insurance premiums also.
And in many respects, we really need to start in kindergarten or preschool, because the habits that we have seen have developed over time. Poor oral hygiene is something that we see in at least my veteran population, and that contributes to a number of other types of issues. Lung cancer is one of the high diseases, or we have a higher percentage of patients with lung cancer than any other kind of cancer, and that is a choice in some respects. And so I think it is, how do we teach people at a young age those wise choices of exercise, good eating, and good habits. And it's going to take generations starting at a low age, because when you get to be 50 or 60, those things are hard to change. But maybe we can start in the schools. And I know that there's some activities here locally, that there are groups that are wanting to do that. There's some grants that are being proposed to be able to start working in the schools at a younger age to get them into those healthy habits that will then last them a lifetime.
Go ahead, Peggy.
I think, just to add on to that, I know that maybe when the teenagers come home from school, a lot of them are using, they're on their cell phones or they're on their iPads. And I know I have a tendency to do that as well. But unless we use them, as Dr. Kalinda suggested, in that we use them to become healthier, we may have to maybe decrease the use of them so that we can get our children out there and more active so that they can be, healthier and productive adults.
And as I said in the beginning, is in our hospital delivery system, 45,000 plus employees. These employees are our asset to provide care to all of you. We have to make an investment in that asset, and as Darryl said, the returns on that, it really doesn't end up costing us more. It saves us because we have a healthier workforce, which don't have tardiness, they don't miss work because of other issues. Then we're able to be a better employer. And I think, as a challenge, I encourage all of you to consider your employees as your, not that you don't, but from a healthcare perspective, consider them your biggest asset, and I think the returns you get will be unbelievable. Why don't we thank the panel? We appreciate them for being here and their time and commitment.